Hello, everyone. I'm Bob Levine, and we welcome you to our AO Hotseat Legend Series, where we interview a true legend who has catapulted our profession forward through clinical studies and mentoring of others. It is truly an honor to introduce my close friend and mentor, who has left an indelible mark on the field of periodontology and phenotype modification, Dr. Preston Dallas Miller. His friends know him as PD Miller. My co-hosts are friends and periodontal colleagues, Dr. Alex Lynn, PG Director of Periodontology at University of California at San Francisco, and Dr. Shayan Barootchi, who is in private practice in Canton, Michigan, and has faculty positions at the University of Michigan and at the Harvard School of Dental Medicine. Dr. Miller is a world-renowned periodontist, mentor, American history enthusiast, and author whose contributions to our profession have shaped the way we practice today. Hailing from Memphis, Tennessee, he has dedicated his career not only to clinical excellence, but also to the education and mentorship of countless periodontists like myself. His commitment to teaching has spanned 4 decades with distinguished tenures at the University of Tennessee and the Medical University of South Carolina. PD is the founding member of the prestigious International Society of Periodontoplastic Surgeons in 1988 and is rightly known as the father of periodontoplastic surgery. His expertise, wisdom, and unwavering dedication to improving patient care and education inspire not only seasoned professionals, but also the next generation of periodontists, as well as his treated patients. We will discuss the Miller classification for root coverage, which was published in 1985 and is still considered the guidepost to our specialty and is notably referenced in every subsequent publication on the topic of root coverage. In addition, in 2014, his publication on the Miller-McIntyre Periodontal Prognosis Index, which was known as the MMPPI, received the Clinical Research Award in Periodontics given by our profession in 2015 as the most significant clinical study in the previous year in our profession. It is presently called the Periodontal Risk Score, or the PRS, and gives our patients a similar score as our medical colleagues as it comes to hypertension, hemoglobin A1C, or for men, the PSA, with a target goal for improvement. The PRS is a simple, powerful, evidence-based, statistically validated, and accurate motivational tool and can be used easily in clinical practice for every one of our patients. The benefit to the patients that it shares with them their long-term whole mouth periodontal prognosis for 15 and 30 years, unlike any other index, by scoring the worst molar we are planning to keep. So our conversation with Dr. Miller today will be in 3 parts. 1, PD's background, leadership, and mentoring. 2, the Miller classification of recession. And lastly, the periodontal risk score. All right, PD, I want to introduce you. Hi, PD, how are you?
I'm fine, Bob. Thank you for the kind introduction.
I want to ask you a first question, PD, because we're like sitting in your living room here talking. PD, can you please share with our audience where you were born and raised, and as well as the mentors who influenced you personally?
Well, I was born and raised in the extreme southwestern part of the state of Virginia, 28 miles from the Kentucky line and about 60 miles from the Tennessee line in a town called Northern Virginia. And my father was a general dentist practicing there. And when I think of early mentors, certainly he was a mentor to me. And I could still remember when I told him that I planned to leave general dentistry and go specialize in periodontics, a comment that he made that still rings true to me. He used to call me Bud. He said, Bud, he says, I'm not a periodontist, but if you'll take out those bad upper second molars, you'll take care of the biggest part of your periodontal problem. And I think that has proved true in many, many ways. And other mentors that I've had, and one of the ones, especially from a nomenclature standpoint, was Dr. John Pritchard, who I developed a close personal friendship with over the years.
For the audience, John Pritchard is considered the father of guided tissue regeneration in many ways. So, please continue, PD.
So now, my love of periodontics and dentistry is still being carried forth. I mentioned that my father was a general dentist. My son is an orthodontist, and of course I'm a periodontist. And now I have a daughter who's a sophomore granddaughter at Auburn University, who is in a pre-dental curriculum, who at this point would like to be an orthodontist like her father. So we have the potential for having a fourth generation dental family on that. I'm very proud of her, and she's a good student and very dedicated. I think will be an outstanding addition to our profession.
Terrific. Anything else you want to add?
Not at this point.
Okay.
You lead me where you want me to go, and then I'll add those comments.
Okay. Shayan, please take over.
All right. Well, thank you. Dr. Miller, I'd love to ask you about how the idea of the Miller classification came about. It would be great if you could talk about it a little bit, how the idea was conceived, and walk us through it.
Well, I mentioned early mentors. I'd also like to mention Dr. Les Binkley, who was my partner at the time, because in the publication, which was in the International Society of Periodontics and Restorative Dentistry, I wanted to talk about the predictability of this. And in doing this, I reported on 100 cases, which took me probably 3 years to accommodate all those cases. And when my partner, Les Binkley, looked at it, he says, PD, I believe the classification is as important as anything else, or maybe more so. And I would suggest that you do that as a separate article. And nothing could have been truer from the truth. And so I'd like to credit Dr. Binkley with guiding me on that.
Can you share the story, PD, why you thought 100 cases were important? We just recently talked about that.
Well, I live in Memphis, Tennessee, and Memphis, Tennessee has a population of a million. At the point, I had no academic credentials and figured that if I presented 6, 8, 10 cases, that would have no impact. But because I was a virtual nobody in the profession at that time, I felt that I needed to overwhelm the profession with a large number of cases, which perhaps would get the attention of my profession.
I want to share the story with Herman Korn that you've talked about. I mentioned to these guys also about it.
Many of you all know Herman Korn.
Yeah.
I published the article. The article came out, and I was doing surgery. And a receptionist gave me a call and says, Dr. Herman Korn is on the phone and wants to talk to you. And I thought, well, one of my colleagues is pulling my leg on this. Herman Korn's not going to be called up for nothing like me at this time. So I went to the phone. I says, hey, Herm, how you doing? Damn if it wasn't him. And I immediately came to attention, and he went into this, and he said, I just read your article. He said, I wanted to discuss this with you. And we talked for about 10 minutes. And I said, Dr. Korn, I said, I'm in the middle of doing a surgical case. Could we talk later about this? He says, what are you doing tonight? I said, well, nothing. He says, I'm going to call you so-and-so and so-and-so. Click. And he hung up, and he called me that night. And I guess we were on the phone an hour and a half. And he became a dear friend and colleague after that.
Great story. So this is the Miller classification that PD published back in 1985, I believe it was, from a textbook.
That's correct.
Yeah. So we know PD as the father of periodontal plastic surgery. We interviewed him for a compendium special issue back in 1997. So this is how we got this in the publications.
So Dr. Miller, the next question that I want to ask you is about the two different classifications. So you published your classification back in 1985, And more recently, another classification, chiral classification, was published in 2011. So could you tell us about the differences between these two classifications, and how do you think about the utilization of these two classifications?
The main difference is in how recessions are treated. For instance, in my class 1 recession, you're dealing with like an upper canine, which has no abrasion on it, and you can coronally position the tissue up there if the tissue is thick enough without any augmentation of tissue. However, if the tissue is thin, it can still be a class 1 with some type of augmentation tissue, connective tissue, alloderm, or something like that. And then a class 3 recession is where you can get partial root coverage. And class 4, you can get no root coverage. And I think that the difference in the two has to do with the treatment of that. And I just think it's clearer and better understood by classification than the newer classification, although I do not want to be critical of my colleagues that have decided that the other classification is the best classification for them.
And it really comes down to the class 1 difference, PD. Is that what you're saying?
Yes, sir.
Okay. Very good. All right. Next question.
Okay. So, Dr. Miller, I really want to ask you about the progression of the field of periodontal plastic surgery. And in particular, I'm curious to learn how you think that periodontal plastic procedures have evolved over the past decade, let's say the past 30 years. And where do you see them heading as we continue to advance our field?
Well, I think the biggest problem is making the public aware of what can be accomplished by periodontal plastic surgery, and educating our general dentists to this and what can be done has been a problem over the years and will continue being a problem. And this is an area where I think we need to do a lot of work on that. And certainly making the public aware of these procedures and what can be accomplished, because some of the procedures are not only for aesthetics, but also are functional. And it's just a field that the public could benefit from this if they can be made aware that these are available and what we're trying to accomplish.
So you're talking about a patient perspective aspect of it. Am I correct?
That is correct. And we don't want to overlook the professional standpoint on this, but it's got to be co-taught not only to the professionals, but also to the public.
And many of the hygienists, for example, are the ones that make the referrals. So it's the education of the dental hygiene team in our offices is very important.
Yeah, that's a great point.
And I could not echo that more great comment, Bob.
Shayan, another question by chance?
What you were mentioning right now lays a lot of foundation and brings a big point about the patient component of periodontal plastic procedures over the past decades. I'd like to know your opinion of what you think has been the evolvement of the field of periodontal plastic surgery from the clinician standpoint, from the surgical standpoint, whether it's with techniques, with biomaterials, with different materials that we have nowadays that were less available maybe 20, 30 years ago. And how do you see this evolving the field, and where do you see the field going from here forward?
Well, I think the development of new materials will continue. And with the development of new materials, the procedures will become simpler to perform and more predictable, and therefore more readily done clinically on that. So I think technology is going to play a great role in that in the future, and we need to embrace that.
Hi, Dr. Miller. So I think you already touched base on this question. So I'm going to ask you about grafting the Miller class 3 root recession. So nowadays, a lot of the social media influencers or in some publications, we started to see more information regarding grafting a Miller class 3 root recession. What do you think in terms of the predictability of grafting these type of the root recession whenever there's an interdental attachment or tissue loss?
Well, first of all, I think the key point on this is how severe is your class 3 recession. In other words, if you have a 5 or 6 millimeter defect, you're not going to have a lot of success on that. However, if you've got like 2 millimeters, and certainly some of the techniques performed by Pat Allen and Alloderm, where he undermines the papilla and can elevate the interdental tissue a millimeter or two, that he can get a higher level of root coverage. So I would say the most important thing is the severity and then the technique in elevating the tissue. Now, also we go back to when I first started. When I first started practicing dentistry, the only suture material that I used was 3/0 silk. And certainly using silk and having to remove that and so forth. But now we're seeing people using 6 and 7/0 tissue that is, suture material. So the improvement in suture material has made a really big impact.
So Dr. Miller, you also mentioned about connective tissue graft and the allogenic graft material. What's your take on the more recent new advancement in terms of the material-wise? Do you think connective tissue graft is still considered your gold standard, or in some cases, scenarios, you may consider using allogenic or even xenogenic graft materials?
Well, I don't want to appear that I'm bailing out on this, but I have been retired since 2008. I suffer from macular degeneration, have not really done any surgery since then. So I don't think I can really evaluate that except to speculate on what may occur. And I don't think this group is interested in my speculation.
As a point we didn't talk about that I think I'd like you to speak about is the importance of the width and thickness of the papilla and height with your classification of the papilla height, because these newer techniques really kind of go into that as to the success rate with them, I would think.
Right. Bob, I don't remember when I published it or where I said it, where we talk about the difference in papilla width.
Yeah.
And the criteria we would like to see a papilla that's 3 millimeters wide.
Yep.
Or is it 2 millimeters wide, or so forth and so on. So the papilla height is extremely important, and using the free gingival graft to take a barbed Parker blade at the level where you want to have the level of root coverage and to spear in that and to create the butt joint margin in the coronal aspect of the papilla, where you can inlay the graft and get primary blood supply in there, I think is important. So I just think that the papilla is a very critical thing, and blood supply and wound stabilization certainly are key factors as we move along in that.
Wonderful. Shayan, any other questions in this section?
Yeah. Actually, I do want to continue on this along the same path. Dr. Miller, I really love that you mentioned about the importance of the papilla and how that provides blood supply. Because in fact, this is something that we have also been researching on a lot, the importance of the papilla and how perfusion and blood flow is imperative to the healing in respect to the neurosurgical procedures. I want to ask you if you think besides the papilla itself, besides the perfusion and the blood flow, vascularity that comes from that, are there other components in your mind that are as equally critical or maybe very critical as well in treating mucogingival defects and gingival recessions, particularly as we're looking at, let's say, Miller class 3 cases or Miller class 2 cases where you have some deficiency in the papilla and you have some compromised papillary defects.
I'm going to throw it back into your lap. Apparently, you are thinking some of these factors. What, in your opinion, would you consider that?
Well, it's an honor for you to ask me about this, but I think in my eyes, I think besides the papilla and the angle of the papilla and the blood circulation that it can provide, I think that perhaps the presence of the keratinization, but not just apical keratinization, perhaps lateral keratinization, and also rotation and location of the teeth, and whether or not they are rotated, whether or not they are buccally dispositioned, can also be really important. That's where my thinking is. I'm curious to hear your thoughts on it.
Bingo, I think you're right.
Thank you.
Any other questions, Alex or Shayan, that we could toss at PD?
So, Dr. Miller, you kind of talk about the different factors that influencing on the outcomes of the treatment. Can you comment on the soft tissue thickness, comment on amount of keratine tissues? What other these factors could potentially contribute to the outcome of the treatment?
Well, I think wound stabilization is always a good consideration on that.
Yep.
And early on in my grafting technique, to get as much exposed tissue to supply blood, I routinely always treated at least 2 adjacent teeth to get as much interproximal raw material, if you will, to supply blood. And also, too, in the mandibular arch, I think you should always come at least 2 or 3 millimeters apical to the recession and do a stabilizing, what I used to refer to as an apical stabilizing suture to strap the graft against that raw blood supply that I'm talking about.
Yeah, the technique is also published by Holbrook and Oceanbean regarding the type of suturing, the stretching, the crossing, and the periosteal sutures. That's what you're referring to,
Right.
PD? Yes, great. All right, Dr. Miller, we're going to go into our last third part of this interview about the periodontal risk score. What made you decide the need for another periodontal index scoring system, which became the MMPPI and presently now known as the periodontal risk score?
Well, first of all, you and I have talked about this subject. Before I developed this score back in the 1970s, 1980s, I did not have this information. And I would tell patients that I really did not know what the outcome was going to be on this. But I used the term, I said, if you want to roll the dice with me, I'll roll with you to see what we can accomplish. And I've also told you this too. I cannot remember a single patient that didn't say that sounds good to me. But now we have the information, and in doing that, I decided that I would go by and look at my patients and try to find 100 cases that I had treated over the years, a minimum of 24 years, that had all their teeth, and see how many that we lost over that 24-year period of time.
How many patients did it take you to get that 100? I remember you.
I think it was 106, and there were 6 patients that I had inadequate data on and had to drop them from the study. And we did anterior teeth, and we did posterior teeth and molar teeth. And we developed a technique where we can very quickly score these teeth based on the most severely involved tooth that you plan to keep, which generally turned out to be the maxillary second molar. And so that tooth scored a 3. Was that not right?
Actually, scored it 2, the highest.
So, yeah, scored a 2. And then that tooth certainly was a multi-rooted tooth. And if it had furcations in it, which it did have furcations in it when the furcations were involved, that we scored them based on not only not the severity of them, but the number of furcations involved. In other words, if you had all 3 furcations involved, then the furcation score was a 3. We also scored mobility. We also scored the blood sugar, whether the patient was diabetic or not.
Well, the 7 factors: age, whether they were smokers or non-smokers, diabetes, molar type, as you mentioned, probing depth, furcations, and mobility.
Right. And then we found out that after a 24-year period, that if a tooth scored an 8 on that, there was a certain liability on that. And if we could keep it down to a 5, that the patient could pretty well maintain that tooth for a 15 to 30-year period. So the goal was to score, to create a score of 5 or less.
So that's our target goal, is what we call it, is a score less than 5. But the tooth that you're talking about, the worst tooth we're planning on keeping, and if it's a molar, second molar, that'll score the highest. So we try to go with that tooth, which would be considered a 2 on the score sheet. That's a reflection, and it reflects on the status of the whole mouth, not just that tooth. And that's the beauty of this, the periodontal risk score. Correct? You did.
Exactly.
Yeah, so you don't have to score the whole mouth. You score the worst tooth you're planning on keeping. And that is a reflection. You could do that just in a few minutes, that you plan on keeping. And a reflection of 15 to 30 years.
Hygienists can do this
Yep.
just as well.
Yeah.
And it takes about, what would you say, Bob, 15 to 30 seconds?
Yeah, it's less than a couple minutes, that's for sure. And then, knee to eye to eye, we explain it to the patient. They have a good understanding. It's very motivational, as mentioned in the quote of PDs above. So our target goal is less than 5. And as you shared with me, the thing that you didn't see much of, because the multi-medications that patients were taking wasn't apparent at that time. If you had diabetes, you're on one medication, hypertension maybe one. But now with the advent of what we see every day as dry mouth, because of all these other medications such as anti-anxiety, antidepressant, and whatever, they all piggyback to create a situation of dry mouth and loss of teeth due to caries. So statistically, when I talk to patients, it's a score that tells them that they shouldn't lose their teeth for 15 or 30 years to periodontal disease. And if they have these multiple situations of dry mouth, and you just ask the questions, and you could tell them they have a dry mouth based on the medications they're taking, we got to take that into consideration, that MIX, medication-induced xerostomia, will affect whether they're going to keep a tooth or not. But we always say the keys to success is following, the compliance, reducing your blood sugar, smoking cessation, which is really important. Either you smoke or you don't smoke, and adhering to the final, whatever the periodontal regimen would be for treatment and also for after treatment and the care. So this is something that we reinforce with our patients through the initial visit, as well as all the way through every periodontal maintenance visit after that.
Now, we talked about the Miller-McIntyre Periodontal Prognostic Index. That is, I think, a little bit confusing to the patient. And the term periodontal risk score, I think, is better understood by the patient, because I'm not sure every patient understands the word index, and yet they know when you say score, they know exactly what you're talking about. And so I think from a communication standpoint, it's easier to talk about the PRS than it is the Miller-McIntyre. And the thing that troubles some professionals, it sounds like we're giving the patients a guarantee. That's not the case at all. We're giving them the facts, and this is typically what should happen. Certainly there are outlier cases on that where perhaps this would not be true, but just giving the facts and letting them decide what's best for them. And although I did not have the opportunity to do this when I was in practice because I didn't have the score then when I stopped practicing in 2008, I think dentists will find, hygienists will find that a significant number of patients are going to walk in and the first thing they're going to say is, what's my score?
Yes. And they have done that. And the beauty of this is you're saying at the bottom, if you have family or friends interested in saving their teeth, we welcome your referral. And that's you in your private practice hat on, saying that, let's share this with everybody because this is available. And if you want to keep your teeth, here we are. So that kind of leads into the next question, which has become really important in the periodontal implant community. So a recent CBS News report highlighted concerns about some dentists extracting healthy, treatable teeth for profit, leading to unnecessary procedures as all on X and contributing to what we all see as a growing crisis of peri-implantitis. So PD, what message do you have for the next generation of dentists about ethical considerations and the decision-making process involved in tooth extraction, tooth replacement, and the role of the PRS in guiding these choices?
I think I've really already answered that question. I think we have an obligation, a moral obligation, to explain the situation to the patient and let it sink into them. And then if they come back at the next recall of patient appointment and have further questions, we can answer that. But I think we can make a real impact on that. And as I've told Bob many times, my classification of recession compared to the impact that the PRS could make is much greater on the PRS.
Yes, and we thank you for both of those and your contributions to periodontics in general, but also into saving teeth, because this has become something of a concern for many of us periodontists, because we save teeth all the time that have furcations, because the case kind of reinforces what we're talking about. I mean, this is a case that presented to me, we published in this article together, of a patient who did not want another round of full mouth surgery. He wanted to save his teeth. He was told that he probably would lose a lot of these molars. They all have question marks or furcation invasions. And this is where the PRS really is important. The molars aren't terribly mobile. There's some very deep pockets, class 2 furcations. Lower left may have caries in the furcation of number 19. Decided to score tooth number 3. And we can see there's a lot of bone loss, generally speaking. And this is an easy case for a clinician to say, you got these molars that need to come out. Why don't we just take out all the rest of the teeth? 30 to 50% bone loss, maybe in areas, maybe a little bit more anteriorly. We take our pictures. We have the discussion with the patient. The PRS score becomes a 7 using tooth number 3. So we still have a prognosis of 15 years. And this is a gentleman who's post Vietnam, and he's in his, I believe in his 60s, I forget, or early 70s. But when we look at he's a non-smoker, quit about 10 years ago. We can see we're scoring the first molar furcations. He has 2 of them on tooth number 3, mobility of 2. The total is 7. We look at our score. Our target goal is less than 5. 15 years prognosis is 86. So he's concerned more of the 15 years. So we go through periodontal treatment. The keys to success were followed by the patient. His plaque control was excellent. His compliance history with our office every 3 months was excellent. And we can see the power of this. We were able to follow him for 4 years. He was able to keep his teeth. We reduced the score from 7.6 to a 5 and maintained that. He did not lose any of his teeth. So the beauty of the PRS, it aids and to motivate the patient as well as the clinician to save teeth, because the PRS is statistically validated and it's accurate and a great motivational tool for our patients. So if we could open things up for everybody, and Alex and Shayan, any questions?
So I think one of the questions that people always have is about the smoking. As we all know, that the smoking is the biggest factor that weighted in the PRS system. So people always wonder, how about the ex-smoker or smokers that or people that who recently just quit smoking? How would we really gauge the influence of smoking on these patients with this system? Dr. Miller, do you have any insights on this issue?
I'm thinking of one patient that I had who was a 2-pack-a-day smoker, and he developed lung cancer. And as he died, his soft tissues looked the best that they could possibly look on that. And I don't think we can judge long term what smoking cessation does, but then we just have to speculate on that and assume that smoking cessation does have a positive influence on that.
I had this conversation with PD when we kind of relooked at this MMPPI and made some changes. As we know with the literature, and Alex is noting because he's a postgraduate perio director and knows the literature better than anybody, there's different stages of smoking. And Alex, if you want to mention that after, but when PD and I decided to get rid of the, smoking 0, 1, 2, 3, 4, we wanted to simplify this. Our goal was to get these patients to quit. There may be a difference, as we know in the literature, a recent smoker to somebody who just quit smoking, somebody who quit a few years ago may be different. But we want to get to the point to the patient, stop smoking. This is the biggest effect. You have a 250% chance of losing your teeth. And obviously we quit smoking. That's the numbers that a 4 is subtracted. And the easiest way to get to less than a 5 is quit smoking. So can you explain that, Alex, a second?
Yeah, because I feel that if we look into the most recent 2017-2018 World Workshop in the staging and the grading, in especially the grading part, we have grade A, B, and C. And AEP, EFP made it very clear that grade A, which is very slow progress of the disease, is going to be non-smoker. And grade B, which would be a moderate progression of the disease, would be people that who smoke so-called light smoker, 10 cigarettes less per day. And a heavy smoker who smoke more than 10 cigarettes per day would be considered grade C. And in addition to that, Toma asthma, which is a very, very classic article talking about even you quit smoking, the effect of smoking in the body would last probably up to 11 years until your response would be considered almost the healthy non-smoker. So literature has been telling us that smoking could be a very long-lasting event that would always have the impact in our body until 10, 11 years down the road. And I think this is a very difficult question to really answer since we don't really know the interaction between smoking and the body and how much impact on the tooth prognosis and long-term survival. Maybe in the future, some future research would be able to help us on identifying this impact. And I wonder if there will be any modifications down the road in the future to modify this system.
It is. That's a definitely big question. But, the patients that, we're not going to affect every patient who quit smoking, but our goal is to get them down to less than 10 or less than 5 cigarettes. And that is my goal all the time because, we think we used to do this with implants as well, trying to quit them, either have them quit or get down to, less than maybe a quarter of a pack a day. So thank you for adding that in, Alex. Shayan, you want to add anything to this conversation?
Yeah, you, PD, and Alex actually brought up really good points. I had nothing to add. I just think that I would hope that people will utilize this more and more, and not just this particular, but overall, whatever tools and means that we have for teeth preservation. There are a lot of things that we have in our toolbook now for trying to maintain teeth, and keep them long or regenerate softer hard tissues. And I just hope that we go along this path instead of the path of just taking out teeth, instead of leaving them as really just last resort, the option of extraction. And I'm glad that we're able to touch on this as well.
Yeah, because the younger the patient is, the more crippled we make them by taking their teeth out, because it's really a tsunami of periimplantitis that many of us have seen over the last number of years. And, we were at the APAO consensus this past summer in Chicago on a topic that when I took when I took the Branimar course in 1986, it was like taking my boards, I never thought we would have a 2-day workshop and a consensus just on this topic. I mean, it wasn't even a word in our literature in 1986. So this is something that is really important. And as PD mentioned, this is where he wants to be really leaving his footprint and fingerprints on is the PRS. He loves that we use the Miller classification, and we still use them with our patients on recession. But the PRS in saving teeth is really where we, as periodontists, should be thinking about. So let's wrap this up. I want to say, PD, it's been my pleasure to visit you in Memphis, and we're in horse country also. And I'm glad you're doing well. He's had a minor surgery, not so minor, but a recent surgery that he's really recovering well from. I would say Alex and Shayan, thank you for co-hosting with me, and you were able to meet PD, and it was great seeing you, PD. Any closing words from you, my friends?
For Shayan, Jim, I also have a website, pdmillers with an S, webtextbook.com. And the information on the PPI is in there, but I have not upgraded that to discuss much about the PSR. But please feel free to use that. And I'm available at most any time you'd like to give me a call, and we can have an intellectual, professional conversation on this. If you would so be interested, I would enjoy that.
Great.
Absolutely. That would be fantastic.
Yes, that would be a great opportunity for sure.
Okay, well, thank you all for attending, and we will see you again soon.
Thank you.
Take care.
Everyone, take care.